Thank you, Rochelle. Well, good morning, everyone. My name is Mandana Khalili. I'm the director of the Investigator Development Unit here at the Research Coordinating Center. On behalf of the UCSF Research Coordinating Center and Investigator Development Unit of the NIMHD, Multiple Chronic Diseases Consortium, I would like to welcome you to our monthly webinar. Adele, yes, thank you. Before we start, we'd like to acknowledge the Ramaytush Ohlone people who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place the land that UCSF sits upon, their home. We are proud to continue their tradition for coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. Wonderful. Well, today we are honored to have Dr. Orlando Gutiérrez speaking to us about disparities in the development and progression of kidney disease in the United States. Dr. Gutiérrez is currently a professor of medicine and epidemiology, Marie Ingalls Endowed Chair in Nephrology Leadership, and director of the Division of Nephrology at the University of Alabama at Birmingham. Dr. Gutiérrez also serves as a deputy director of the Center for Clinical and Translation Science. The primary focus of his group has been elucidating the mechanisms by which disorders of bone and mineral metabolism and nutrition impact outcomes in individuals with chronic kidney disease. His group has also focused on how environmental and genetic factors impact disparities in cardiovascular and kidney disease. He's an elected member of the American Society of Clinical Investigations, and in addition, he has a track record of publications, including feeding studies using physiological endpoints and other high-impact studies that have highlighted the associations of nutrition, obesity, metabolic disease, and environmental factors with outcomes in the general population and in individuals with chronic kidney disease. Dr. Gutiérrez, we're looking forward to your presentation.
Thank you so much. Appreciate the invitation. And as I'm sharing my screen here, happy to see many of my friends at UCSF are signing on, and many of my friends in the immediate area from Auburn and UMMC and so forth and UAB. Great for all of them to join us and to be able to present on behalf of the Deep South Center to Reduce Disparities in Chronic Diseases. One of the centers is part of the consortium mentioned earlier. This is the table of contents of what I'd like to review over the next 45 minutes or so. And we'll start as a level setting procedure in terms of talking about the epidemiology of chronic kidney disease in the US. Then that will provide the foundation to discuss disparities in CKD in the US. And then some of the factors that likely underlie the vast majority of the disparities, including contextual factors and then biological factors, and we'll summarize at the end. And I hope to have the opportunity to answer questions and interact with anyone on this feed at the end. One thing, just as a disclaimer up front, it's not my intention to discuss during this 45-minute period of time anything related to do with estimated GFR equations or the inclusion of race in the estimation of GFR. My not discussing that is not because it's not an important topic. It's just that it's so complicated and it takes so much time to go through that I wanted to focus on these other areas. But if there are questions related to that, I'm happy to answer those at the end. So again, as level setting, and I know on the scope of individuals in the panel right now, there are many healthcare providers, but just to make sure that we're all on the same page, I like to present this just as a way to introduce the kidneys and how we estimate their function. Of course, this is, and on the right, some pictures of the kidneys, where they are, and generally their size. Their major purposes are to filter the blood of waste products normally produced every day, control levels of fluid, salt, and other minerals in the body, and produce a number of important hormones that are necessary for making new red blood cells in the bone marrow. When we think about how we can measure or assess kidney function, what we start to think about and what we normally use is on the left, we focus on a particular functional unit of the kidney called a nephron. And in a nephron on the right, you will see that there are a number of, there is these what are called glomeruli, which are essentially thin-walled capillary type structures through which the blood is filtered, and then that filtrate goes into the proximal tubules and will eventually become urine at the end of these tubules. One of the primary ways in which we assess kidney function is we assess what's called the glomerular filtration rate, or GFR, and that is essentially the rate at which the blood is cleared of a substance, for example, a toxin, creatinine, blood urea nitrogen, for example, over a period of time, normally mils per minute, and often indexed to body surface area so you can standardize across individuals. And so, as you will see, GFR becomes a major factor that we talk about with respect to kidney function. So there are other ways of assessing kidney function that one can look at. We won't review those in this particular talk, but that's why we're focusing on GFR as a major functional unit to assess kidney function. With that background in mind, what is chronic kidney disease? Chronic kidney disease is defined as either having kidney damage or a glomerular filtration rate less than 60 mils per minute per 1.73 meters squared. So again, that indexing to body surface area for at least 3 months. And that at least 3 months part of it is just to make sure that any abnormalities, either with respect to kidney damage or lower GFR, is not a transient property, but something that lasts for a period of time, so that it's truly chronic. Now, the kidney damage, that's the part of this definition, would include pathologic abnormalities or markers of abnormalities, including blood or urine protein that appear in the urine that's not supposed to be there, or imaging studies suggesting that there are morphologic changes or other aspects of the kidneys that are abnormal. And again, that the abnormality lasts for at least 3 months. Now, many of you may have heard the staging of kidney disease, and this staging has really evolved quite a bit over time from its first manifestations to what I think is pretty well solidified now. And what you're seeing here on the screen is an overview of staging of kidney disease. Staging of kidney disease is based really on 2 axes. One is GFR, which we talked about before as the major functional unit that we use to assess kidney function. The other major aspect of kidney function that reflects kidney health, if you will, is levels of albuminuria or albumin excretion in the urine. That is the other way in which kidney disease can be staged. And as you can see, you can have different levels of kidney function that are defined based upon these 2 axes. You can have individuals in this box we have here who have normal GFR and have normal levels of albuminuria. So these are people who have completely healthy kidneys. And you have people on the other end of the spectrum, in this bottom right corner here, who have very low GFR and very high levels of protein in the urine. And they're in the red because we know that these are individuals who are at very high risk of kidney disease progression, as well as cardiovascular disease and death. And you can see that there are many different sort of manifestations in between, with the green boxes denoting individuals who are generally considered to be healthy. I will call this beige, at least on my screen, these are beige boxes, individuals who are at intermediate risk, and in the red are individuals who are at the higher risk of various outcomes. You can also see here that these stages go from stage 1 to stage 5. The higher the number, the worse the level of kidney function, defined by these different cutoffs for GFR. And you will notice that people, in terms of the definition of CKD, is really anyone who has stage 3 through 5, which means by definition your estimated GFR is less than 60, has evidence of kidney disease. If you have greater than 60, but you have some proteinuria, you can also be classified as kidney disease. But for the most part, when we talk about kidney disease, particularly in the outpatient setting, we're mostly referring to people who are in stages 3 through 5. With that further background, then we look at the prevalence of CKD in the United States, and we mostly talk about this with respect to stages of kidney disease as indexed by GFR, largely by GFR. And these are older data, but still pretty relevant in terms of the prevalence of kidney disease in the US. At the time that this particular study was done, about 11.5% of the entire US population have kidney disease, but it's really an age-related phenomenon. And you can see that on the overall slide here, that's broken up in the lighter box with NHANES, the third wave of NHANES, and then the more recent waves from 1999 to 2004. Irrespective of which wave of NHANES was being looked at, the older you are, the higher the prevalence of CKD in this population. And if you look particularly above 70, you're approaching almost 45% of individuals over the age of 70 have evidence of CKD, largely GFR less than 60. So really a very, very, very common issue for older populations, and almost, if you will, it can become universal if you get old enough. And you can see that most of the CKD in older individuals is largely the stage 3 CKD. So this is individuals who have estimated GFR less than 60. When you get to more severe stages of CKD, the prevalence by age and the differences in prevalence by age become lower. So with that background in terms of the epidemiology of chronic kidney disease, what do we know in terms of disparities in chronic kidney disease? And there have been a number of studies that have looked at this over the years. This is one that was published in a review by a number of investigators in 2013 that was trying to make 2 points. One was that there are important differences in the prevalence of CKD by race and ethnicity, at least as we're seeing in this slide. If you look at the relative prevalence of stages 1 through C CKD, so individuals who have very early stages of CKD, with white individuals here being the reference group, you can see not much difference in terms of the prevalence of CKD, early stages of CKD in Black individuals, and truth be told, not that much of a difference in terms of Hispanic individuals using NHANES data. But if you look at the prevalence of ESRD using USRDS data, so people who have progressed to kidney failure requiring kidney replacement therapy, you start to see much more stark differences in terms of the prevalence of end-stage kidney disease, with, again, white here being the reference and Black individuals here being 4 times more likely to have or to represent the population of individuals with end-stage kidney disease, Native Americans having higher risk, individuals who self-identify as Asian race, and individuals who are Hispanic also having higher risk. So the point of this is to say there are certainly disparities in the prevalence of kidney disease, but those disparities seem to track with severity. Doesn't seem to be as much severity in the early, or much differences in the early stage of kidney disease. Where you really start to see disparities is in much more severe stages of kidney disease. And this is another way of sort of looking at that. This was a modeling operation or a modeling procedure that Morgan Grams and colleagues did a number of years ago, in which they looked at and they modeled the cumulative incidence of different stages of kidney disease, this time just by race and sex. And what they observed is if you look at the very earliest stages of kidney disease, so stage 3A or 3B, these 2 panels here, and you look at the modeled cumulative incidence of these early stages of kidney disease over time, what you can observe is, as we've seen before, the older you get, the more likely you will eventually develop CKD. But if you try to look for differences across lines here, with the solid lines being Black individuals and the dotted lines or the dashed lines being white individuals, not huge differences over time. Perhaps when you start to get older age, you start seeing differences. And the same thing when you look at stage 3B, again, early stage kidney disease. When you look at sort of this modeling exercise in terms of cumulative incidence of late stage kidney disease, so stage 4 or 5 individuals who require kidney replacement therapies, then you really start to see that the modeled cumulative lifetime incidence of stage 4 or 5 CKD differs quite dramatically by race in this particular example, with Black men and women having a higher risk or higher model cumulative incidence of CKD 4 and 5 than white men or women. And this has been a very consistent finding. This is a modeling episode, but if you look at a number of different cohorts, this has been a very consistent finding that the disparity in terms of kidney disease really is for the more severe stages of kidney disease. It's not to say it doesn't exist in earlier stages, but it's much more prominent in the late stages of kidney disease. And in trying to understand why that might be, there have been a number of studies that have looked at the sort of the natural history of kidney function over time to understand, well, what is the sort of the progression of kidney disease or kidney function over time by race and ethnicity. And this is one study done by Carmen Peralta, who I believe still has an adjunct professor position at UCSF. But she was using the coronary artery risk development in young adult study to look at the change in estimated GFR based upon a cystatin C-based estimated GFR in Black and white individuals in Cardia. And the nice thing about Cardia, as many of you know, it started following people at a very young age and then has been following them really for the past 35 years. So it offered an opportunity to be able to look within persons or within groups over time at the sort of, if you will, natural history of kidney function decline over time in these two groups. And so one thing you can say up front with this figure is that as all of us age, we lose GFR over time. So that's just a natural part of aging. And again, part of the reason why at least this definition of CKD is so highly prevalent in older individuals. But one insight that her paper showed here, and this line here reflects Black individuals or people of self-reported Black race, and this line, dashed line here, represents individuals who are self-reported white race. Don't pay attention so much to the differences in the lines that may or may not be meaningful in terms of where Black individuals are starting versus white individuals. What I would ask you instead is focus on these two sort of arrows. And what these arrows basically are showing is the point in life in which GFR starts to decline, or an inflection point in which you start seeing the mean GFR really start to decline in the two groups. And among Black individuals, that mean GFR starts to decline much earlier in life, in the mid-30s perhaps, as compared to white individuals, in which you start to see this inflection downwards occurring more so in later ages. So one of the insights from this study, and it's been shown in other studies as well, is that Black individuals, at least in Cardia, but again, been shown in other areas, the decline in GFR appears to occur earlier in the course of life. And then once GFR starts to decline, the slope of the decline is more severe. That is to say, on average, when GFR is going down, it's going down at a faster rate among Black individuals than it does among white individuals. And perhaps this provides some clues as to why in early stages of kidney disease, there doesn't seem to be that much of a difference in terms of prevalence of CKD, but it's largely in the late stages of kidney disease, because by the time you get to late stages in Black individuals, you've already had a faster decline that has been occurring for a longer period of time. This is also relevant to other individuals, including Hispanic individuals. And so this is another study by Dr. Peralta that was done in the multi-ethnic study of atherosclerosis, about 5,000 individuals in that study. And they looked at participants in that study who were free of CKD at baseline. And what they did, and I asked you strategically, I put this yellow box here because I really want to train your eyes in the yellow box. What they did is they looked at the relationship between ethnicity and the decline in just estimated GFR over 5 years in these participants by ethnicity, and then breaking up Hispanic individuals into countries of origin or areas of origin, if you will. And so the first thing that they observed is that comparing individuals who were Hispanic to white individuals, Hispanic individuals tended to have a faster decline in DFR over time than white individuals, similar to what was observed in the data in Cardia. What was interesting, however, and we'll start with the caveat that the numbers get very small here, and so the precision around these estimates becomes more challenging. But what was very interesting here is that it appears that the decline in GFR that was seen in Hispanic individuals as compared to white individuals in the study appear to be particularly predominant in certain subgroups of Hispanics. So individuals who are of Dominican ancestry and individuals who are of Puerto Rican ancestry. And as someone who has myself Dominican ancestry, obviously these results caught my eye. I don't focus so much more on the 95% confidence intervals, again, because the numbers are getting small, but if you look at least at the effect estimates, certainly a difference on face value numerically from individuals who are, for example, South American or Mexican American as compared to individuals who are Dominican or Puerto Rican. And so while it certainly seems the case that Hispanic individuals also have faster progression of kidney disease or faster decline in kidney disease over time as compared to white individuals, there's a nuance and I think a flavor there that it appears to affect certain groups. And as I'll argue later on, I think there's a potential explanation for that, but one of them, just to present that up front, is that individuals of Dominican descent and Puerto Rican descent generally have a higher representation of individuals who have more recent African ancestry. And perhaps that is part of the reason why we're seeing some of these relationships. That interesting observation and certainly speaks to the disparities of GFR decline in Hispanic populations. Now, is this a static factor? And it's not. And I think I saw Dr. Delphine Tuot sign in earlier, so I'm thrilled because I'm happy to present her data along with other colleagues, looking at the prevalence of stage 3 and 4 chronic kidney disease in U.S. adults over time in the NHANES, just to see is this becoming a worse problem? Is this stabilizing out among different race and ethnic groups? And you can see here the different waves of NHANES and then the prevalence of chronic kidney disease here on the y-axis. And what you're seeing here, I think the half glass full aspect of this figure is that among non-Hispanic Black individuals, non-Hispanic white individuals, and other races and ethnicities, it seems like the rates which appear to be going up when you're going from to the third wave of NHANES to the late 1990s, early 2000s, it seemed to be going up, and it really seems to have plateaued over time in those races and ethnicities. Still higher in overall among Black than white individuals, but not a major difference in terms of the rate of or at least not the rate, but the prevalence of CKD in each of these particular waves. But if you look at Mexican American, see a very different story, in which it appears that the prevalence is increasing over time in a way that it's not increasing as much in these other race and ethnic groups, which is a troublesome observation, and obviously something that requires some more investigation and mitigation, frankly, because ultimately, if these rates continue, we'll have a large wave of individuals of Mexican American ethnicity who are becoming more and more prevalent in a total U.S. population, who will develop kidney disease and end-stage kidney disease with major public health manifestations. So on some ends, we at least have stabilized the prevalence of CKD over time, but in other races and ethnicities, the problem still seems to be getting worse as time goes on. I wanted to present this figure. It's again a little bit older, but one of the better studies just to make this point, because the disparities affect everyone or can affect everyone. And what this is showing is USRDS data looking at the cumulative incidence of end-stage kidney disease from birth in different races and ethnicities. The circles here, this is by men on the left and women on the right. So the circles here on the bottom here is the cumulative incidence of ESRD as a function of age among white individuals over time. You can see that's the lowest curve. So white individuals generally have the lowest risk of developing end-stage kidney disease. As we've seen elsewhere in this line up here, these are non-Hispanic Black or African-American individuals, the highest incidence. But then you can see some of what we've seen before, Hispanic individuals in men at least higher. than white individuals. Pacific Islanders, largely American Samoa, people from American Samoa, excuse me, are higher than white. And then hidden under this black line, which is the composite, these triangles are non-Hispanic Native American, also higher than the white individuals. So again, just making the point that this is a really important issue for many races, for many ethnicities, and these disparities are important to understand in order to be able to act upon them and mitigate them as much as possible. These relationships remain very, very similar in women as in men. I didn't mean to focus just on men for that purpose, but just to make the point that in both women and men, we see these disparities that track with race and ethnicity. So then understanding sort of the breadth of the problem in terms of disparities in CKD, what are the major factors that seem to be underlying some of these disparities? And this is a figure which sort of encapsulates many of much of the thinking in terms of the major factors that ultimately lead to these disparities. You can take out chronic kidney disease at the bottom of this figure and replace it with a lot of other chronic diseases, and this figure really wouldn't change very much at all. But I think it's still very much relevant to just review the key social cultural determinants of CKD. Genes, biology, and environment certainly play an important role. We'll talk a little bit more about this issue of biology later on, but we know quite well some of the issues with respect to marginalization, discrimination, racism, issues with respect to poor communication, distrust, and chronic stress, and some of the work that's being done looking at the physiological effects on that, issues with respect to residential segregation, overcrowding, poor housing, which feeds into a number of these other aspects, include underemployment, poverty, limited health access, which sometimes can contribute to substance abuse, leading to downstream consequences such as poor nutrition, the intermediary markers of disease like obesity, diabetes, hypertension, cardiovascular disease, all of which can contribute to chronic kidney disease. So this is a very, there are many multifactorial reasons why people develop kidney disease, but also multifactorial reasons why disparities occur in kidney disease, because the manifestations of many of these boxes does not occur in only one group. It disproportionately affects African Americans, disproportionately affects people of Hispanic ethnicity, and really just taking out of race and ethnicity disproportionately affects people with low socioeconomic status or adverse social determinants of health, which drives, I would say, the lion's share of these disparities in kidney disease. Just to show some of these data in sharper relief, this is one of the first studies that kind of showed this in detail, looking at the relationship between the population who is below poverty in a particular census tract and the incidence of end-stage kidney disease in individuals in the United States using USRDS data by Dr. Volkova and the late Bill McClellan, who's done a lot of the great work in disparities of CKDs over the years. And they looked at stratified by men and women 50 to 60 years old. And what they observed at the time, it was a really important observation, is that where you are in terms of your residence in terms of census tract and the percentage of population below poverty in that census tract was an important determinant of the incidence of end-stage kidney disease within individuals in that census tract, whether you're male or female. And this was relevant both for Black individuals as well as for white individuals as well. This was a observation that helped to also confirm a seminal study that came out of UAB, Stephen Rostand, New England Journal of Medicine in 1982, which is one of the first studies to document that Black individuals disproportionately represented the population of individuals in dialysis units in Birmingham, Alabama, and really got individuals looking at this with a little bit more focus in terms of what are the major reasons for that. And certainly living in areas that have a lot of poverty seems to be an important factor that contributes to that. Another issue that likely contributes to that is issues related to access to care. And this is, I think, a clever study done by a number of investigators a number of years ago, which looked at, again, largely relying on USRDS data. They looked at the relationship of whether individuals had pre-ESRD care, that is to say that they saw a nephrologist, a kidney specialist, prior to starting dialysis. The relationship between whether they saw a nephrologist prior to starting dialysis and where they are in terms of geographically in the country. And they asked questions whether there was clustering of areas where they had very low rates of individuals being seen or having access to nephrology care prior to starting dialysis in the country. And you can see here across the United States, these black dots essentially represent nephrology care facilities, dialysis units. And where they have put in the red dots are those units that were in the lowest quintile of the patients in those units having received pre-ESRD care. That is to say, lowest quintile of patients who received or saw a nephrologist prior to starting dialysis. And they found ultimately several clusters. My geography of California is wanting, but I believe somewhere in there is San Francisco in this cluster 1 here in California. You can see some of these other clusters. We are right here in Birmingham. Right here in Birmingham. So we are part of another cluster. You see one in Florida, the Midwest, and there's another cluster in 5. But this sort of gave you a sense of, or gave us a sense of sort of that there are areas in which there are real barriers to access to nephrologists that may ultimately impact why certain people go on to dialysis, because they don't have specialists who can see them prior to that and maybe be able to intervene upon their disease. When they then did a little bit deeper dive and they looked at those factors that were most strongly associated with lack of access to pre-ESRD care, I'll put it, or associated with a facility having low pre-ESRD nephrology care, what they observed in the adjusted model here on the right, that living in a city was associated with low nephrology pre-ESRD care or pre-ESRD nephrology care. Being of African American race was also associated with a lack of access to care. And then being of lower education, having low education was also associated with lack of pre-ESRD care. So this tells us, I think, something about the contextual factors that ultimately impact some of the disparities that we're seeing. Where you live matters. What about the characteristics of the population? If you're in a demographic group that is traditionally underrepresented, traditionally disadvantaged, like African American, that matters. Your education status matters. All these different factors, many of which are out of the hands of individuals, can make a big role in terms of ultimately whether they end up on dialysis or not. And ultimately, perhaps the disparities we're seeing in terms of end-stage kidney disease by race and ethnicity, given that individuals who have low education, African American, and are in urban settings are the ones ultimately that have lack of access to care, and so therefore may disproportionately represent the ESRD population in these areas. It's not just progression of kidney disease in which this seems to be relevant, and this is an important study by Rudy Rodriguez in the University of Washington a number of years ago, looking at about 400,000 dialysis patients who initiated dialysis between January 1995 and December 2002, and they categorized them by race and by the number of individuals who lived in zip codes that were racially segregated versus those that were not. So, or a better way of saying that, zip codes in which there was a high prevalence of Black residents versus a relatively low prevalence of Black residents so for both Black individuals and white individuals. And what they observed, looking just at the survival over time as a function of time, what they observed is that for Black individuals, didn't really seem to matter all that much with respect to whether they were living in an area with high versus low amount of Black individuals. Among white individuals, it seemed to matter a little bit more whether they were living in a very segregated area or not. But what I think is potentially more important, and particularly with respect to access to care, is individuals who survived and did not or individuals who did not get transplantation. So these are all dialysis patients, remember, and these are individuals who did not get transplantation. And here you see the area of residence in terms of metrics of segregation really start to pop up, in which you have Black individuals who lived in areas that were very heavily constituted with other Black individuals, so greater than 75% Black individuals. These are the individuals who are least likely to get transplants, and you can see a similar sort of a difference in terms of white individuals who lived in areas that had high percentage of Black residents, also least likely to get transplants, whereas those individuals, whether Black or white, who lived in areas that had relatively low percentage of Black residents, more likely to survive and eventually get transplanted. So this, I think, again, when we talk about disparities, is an important observation. It's, whether it's poverty or whether it's racial segregation, where you live ultimately, and using that as a proxy for access to care and environmental pressures and so forth, makes a big difference in terms of access to life-saving therapies like having a kidney transplant. I haven't looked at these data with respect to other transplants, but I suspect if someone did, and if someone knows, please say so. But if we did, we would probably see similar sort of associations for other transplants as well. This is a study that I also like to show just to drive home the point. It was published a number of years ago by Paul Kimmel, who's at NIH, with Dr. Paul Eggers at NIH, and it was looking at the association of, again, a number of these contextual factors, whether it be income, Gini index is a measure of income inequality in an area, and residential segregation. And the reason I want to show it is just to make the point that the degree of residential segregation that is where someone is living in these dialysis patients. So these are almost 600,000 dialysis patients who started dialysis between 2000 and 2008. The hazard ratio of death was really impacted by residential segregation, to the degree to which where they lived was highly segregated versus low segregated. Interesting enough, that was mostly an issue for Black individuals, not as much an issue for white individuals. So that might in part be due to the lower numbers of white individuals living in highly segregated areas. But you also see aspects of income playing an important role in terms of survival in these dialysis patients as well. And interestingly enough, in white individuals, maybe a signal for income inequality also being associated with survival in these individuals on dialysis. But again, these disparities track very well with what we know in terms of social determinants of health and some of these contextual factors, and drives home the point that if we're going to make interventions ultimately that to improve these numbers, we have to think carefully about the environments in which individuals live and how well those environments can be impacted. I wanted to highlight some of the work as well as Dr. Deidre Cruz, who's done a lot of work in this area to look at other factors in neighborhoods that may impact prevalence of kidney disease. And she's done a lot of work on the issue of food insecurity and has published a number of papers. This particular one from NHANES showing the age-adjusted predicted probability of having CKD in NHANES as a function of whether individuals had high, marginal, or no food insecurity as evidenced by a particular metric that they looked at in this particular paper. And what she found was that individuals who had high evidence of food insecurity had the highest predicted probability of CKD, and individuals who had no food insecurity had the lowest. And this was independent of other risk factors that might explain these associations, suggesting whether it's access to healthy foods or food insecurity as a proxy of neighborhoods and neighborhood health. The worse the sort of access to food that you have, the higher your risk of having kidney disease. And she also noted that there was effect modification such that this association was particularly predominant in those who have diabetes as well as those who have hypertension. The other aspects that I wanted to show with respect to this particular these relationships, and just to friends a balanced view of this. I've talked a lot about neighborhoods, and I've talked a lot about neighborhood characteristics and how they impact some of these associations. But there are other data that suggest that it's not all about neighborhood problems or neighborhood cohesions or some of these contextual factors. And so this is a paper that was published a number of years ago by Dr. Hicken, who was looking at the relationship between neighborhood problems and social cohesion with 30% decline in GFR over time in the MESA study that we've referenced before. And she was looking at neighborhood problem score. The higher the quartile, the higher the problem score, or the worse the neighborhood. And the quartiles in an opposite direction here, so the lower social cohesion being the risk factor. And in the fully adjusted model, what she observed in this is that at the end of the day, when you adjust for all these different factors, there was no association between neighborhood problem score, that's a composite of different neighborhood characteristics that speak to neighborhood quality, and the development of decline in GFR over time, nor was there a significant association with social cohesion score. And there have been a number of other studies which have also begun to show that while neighborhood and some of the contextual factors play an important role, they don't seem to play or speak entirely to that issue. This is another example on this front, and I'm realizing now that I may have misspoken, and I apologize for that for Dr. Tuo's work, and I apologize to Dr. Tuo if I did. I believe this was the study that I was referencing, in which they had recently looked at the directed care of CKD patients with commercial insurance or Medicare Advantage. This is a really interesting study in which they looked at in individuals who had commercial insurance or Medicare Advantage, what were the percentage of individuals who received guideline-directed care in individuals who had CKD for ACE inhibitor or ARB treatment, statin prescriptions, nephrology care for people with late-stage kidney disease, or ACR testing. And what they observed, interestingly enough, is that white individuals had the lowest guideline-directed care measures for ACR statins, as well as nephrology care for eGFR less than 30, as well as ACR testing, suggesting that while increasing access and care for individuals is surely part of the paradigm that's required in order to reduce these disparities, perhaps that's not the entire story, since even in those settings in which individuals of certain race and ethnicities appear to be getting good guideline-directed care, we still see that we're still seeing these disparities by race and ethnicity. That will lead to the last part here, which, and I've talked in the last couple of slides, that while contextual factors, neighborhood, residential or racial segregation, social cohesion certainly play an important role, they're not the entire story. And that leads into that there may be other factors that contribute to disparities in kidney disease. And we've learned a lot about some of these factors over time. This is a study that was a really important study that came out that looked at the relationship between certain genetic risk factors called APOL1 risk alleles and their association with several different kidney disease manifestations that are overrepresented in individuals of African American race. And the very high association between having two of these risk alleles and the prevalence of having these risk factors in African Americans, which provided some of the interest in looking a little bit more at APOL1 risk alleles in the African American population. What's been observed is that APOL1 is a protein that's involved in a structure that is important for fighting off trypanosomiasis. And that individuals who have one of these risk variants have increased probability of being able to survive from infection from trypanosomiasis. And so it provides a survival advantage of individuals who have that. However, individuals who have two risk alleles, while they still have survival advantages with respect to trypanosomiasis, they also have a higher risk of developing kidney disease. Which then presents the sort of environmental pressure issue where, on the one hand, these risk variants are protective against infections. On the other hand, if you have two of these risk alleles, you're at a higher risk of developing end-stage kidney disease. And you can see that individuals who have one risk allele, about 46% of self-reported African Americans have one risk allele, about 14% of African Americans have two. And this slide is just meant to show sort of the distribution of this risk alleles, just making the point that here you see where the trypanosomiasis, at least certain species, is endemic in this part of continental Africa. the distribution of some of these risk alleles is particularly heavy in areas where the infection is epidemic, which theoretically explains why there is a higher proportion of individuals who have ancestral descent from this part of the world, while there's a clustering of these risk factors in individuals who have ancestry descent. Let me just take a second, because it's a very important topic, just to say, when we say biologic factors that explain racial disparities in kidney disease, that is not trying to equate race with biology or a specific gene with biology. What it is trying to say is that individuals who have ancestral descent from certain parts of the world have, due to that ancestral descent, a higher prevalence and carriage of risk factors for certain diseases that manifest themselves in the African diaspora that we see in the United States. And we have to just keep that in mind as we think about African Americans, that they are more likely to carry these risk variants, not because of a racial social construct, but only because they're more likely to have descent from a certain part of the world in which these risk variants congregate. If you look at other parts of the world in which these risk variants congregate, getting back to the point of Dominicans and Puerto Ricans, you can see these risk variants are common in the Dominican Republic as well as Puerto Rico, perhaps explaining why you have that faster progression of kidney disease, kidney decline in those Hispanic sub-ethnicities than others as well. This was the sort of the major study that showed ultimately that if you carried two risk variants and you were African American, you have faster progression of kidney disease or faster decline in kidney function over time than if you have one or two of these risk variants. This an important study showed that this, in at least people without diabetes, this is one of the major factors that contributes to faster decline in kidney function in African Americans. Some people have put that percentage, about, it explains 70% of the excess risk of kidney failure in African Americans without diabetes. I think that's probably too high, but it's still an important factor that contributes to that. And one of the reasons I wanted to bring this up is going back to a study that Dr. Peralta did in Cardia. We've seen this before. This is just a different table in that study. And what she looked at is the relationship between white and black race and decline in GFR over time. But then she stratified the population by white race, individuals who are black who had the low risk variants, and individual black who had the high risk variants. And then she looked in different models to see whether the faster progression of or faster decline in GFR over time differed in blacks versus whites as a function of whether they are lower or high risk genotypes. And in the fully adjusted model, which can be seen over here, you can see that African Americans who had the low risk genotype had no difference in terms of the loss of kidney function over time as compared to white individuals. But African Americans who had the high risk genotype, even in the fully adjusted model, continue to have faster decline in GFR over time, which just speaks to, again, the sort of the differential in terms of decline in GFR over time and how biology plays a role, at least for certain individuals. And ultimately, we need to think about that in addition to the social determinants of health in terms of understanding disparities in kidney disease. So to summarize, racial and ethnic disparities in CKD prevalence and progression in the US are clearly profound. And they have been a part and parcel of our country's history in terms of the evidence of kidney disease, one of the most expensive disparities that we have. There is no doubt, and I don't want to make any sort of conclusions that differ from the fact that social determinants of health and other contextual factors play the largest role in accounting for the disparities. Full stop. They play the largest role, and so should be the major focus in terms of understanding how we can impact these disparities. That being said, we don't do ourselves any favors if we don't recognize that there are some biologic factors that disproportionately impact individuals of more recent continental descent that also likely play a role. And if we're going to make an impact on disparities, we have to be aware of these factors and account for them as we develop programs to address these disparities. And with that, I will stop, and happy to stop sharing my screen and take whatever questions that people might have.
Thank you very much, Dr. Gutiérrez, for this outstanding talk. And we are happy to address questions. I think maybe we will start with one This one was asked by Dr. Genski. He was wondering if any of the EGFR or other kidney measures have been evaluated within the context of ancestry markers or AIMS, and if there are any information that you have available on that.
Yeah, it's a great question. And I said purposely I wasn't going to talk about it, but I'm glad you asked me because now I can talk about the GFR estimating equation issue. So the short answer is in a paper in the New England Journal of Medicine in the past 6 months in the chronic renal insufficiency cohort study. They had measures of ancestry-informed markers, and they developed this, and I hate the term, but I'm going to use it because that's what they put in the table. They developed this measure of African ancestry. Which really is just continental ancestry from a certain part of the continent of Africa is what that score really means. But they then correlated African ancestry with measured GFR, not estimated GFR, measured GFR. And they asked the question, if you put this measure of African ancestry, genetically derived African ancestry, in the equation for estimated GFR, does that make it better in terms of calibration of the precision of the equation, or does that make it worse? And what they observed is that they put that measure of African ancestry in the equation and actually helped with the calibration of the equation as compared to, for example, they just use self-reported race. So it has been looked at, and it's an interesting question. I think it's a question of understanding to the degree to which genetic background ultimately impacts the creatinine levels, which are often used for estimated GFR, and how we should consider that in terms of measuring GFR in our patient populations.
Thank you. And I have another question by Dr. Anthony Muro. He was wondering, and I think this probably perhaps is on many of our minds, about how do we really address these contextual factors that drive disparities, and thinking about tackling segregation, income inequity, food insecurity, et cetera, could be quite overwhelming for healthcare providers.
Well, Dr. Murray, I'm looking at you to answer that question, because I think that's really your work in that line is so important for this, but also I think is part of what the center is about, because ultimately we can think about it at multiple different levels. One is working in communities to try to address these very static factors and understanding what interventions can overcome some of these factors. But what we're certainly, and what we talk about a lot in our center in the Deep South, is to the degree to which we can form partnerships with our community members to affect policy, so that we can ultimately work with our elected leaders to address some of these areas, whether those areas be coming together for healthier neighborhoods, access to food, or access to healthcare. And that's a very uncomfortable space, because you're asking healthcare providers to a lot of times get out of their comfort zones in terms of working with community members, and then also individuals who have access to policy. But I think ultimately that's a part and parcel of what the broader chronic disease P50 center mechanisms are, is developing that workforce of individuals, not just healthcare providers, but social workers, nurses, teachers, to be able to do that effectively, because it's at the level of the policy change and that social ecological model that we've all seen, that ultimately some of these disparities are going to be addressed.
Thank you. Dr. Chardebois, you have comments. Please feel free to ask.
Sure. Thank you so much, Dr. Gutiérrez. This is really, really fantastic. Kind of in the context of our multiple chronic diseases initiative that we're all involved in, I was particularly struck by the multiplicative influence of having diabetes and hypertension. Can you comment on where the directions in the field are going to potentially address and impact these multiplicative relationships? How much interest is there? How much attention are these overlapping conditions receiving?
Yeah, well, a lot of interest, not much initiative, I'm afraid, because I think there's a recognition, particularly for people who work in the field, that one needs to be able to address multiple of these different areas, and we get into situations in which the diabetologist is managing the diabetes and the primary care physician is managing the hypertension, and the team-based nature in which these can be addressed concurrently or in parallel is really critical. So I think there's certainly recognition of that in the field. The operationalization of that is more challenging. There's a bit of a revolution, I think, in terms of the care of kidney disease with the advent of the SGLT2 inhibitors and their efficacy in diabetes and some of the other new therapeutics down the line that have impacts both with respect to diabetes, but also blood pressure control. So perhaps utilizing those as much as possible and getting access to those in at-risk communities is critical to be able to address that. But again, really key aspect of what I think this P50 consortium is about is being more intentional in terms of viewing the individual as a whole and their multiple comorbidities and not just doing it as one-offs each time.
Wonderful. And we have time for one last question. Dr. Tuo, you had a question to ask.
Sure. Orlando, thank you so much for a wonderful talk. It's always great to hear your expertise on the subject. I guess kind of building off of Anthony's comments earlier, I was just curious if there are any community partnerships that either you're participating in or the center is participating in that have really been shown to improve access to or linkage to care or try to mitigate some of the socioeconomic structural disparities that we view every day and that you highlighted. I think it's been a challenge to find examples that have really been successful that we can try to replicate in other areas.
Yeah, absolutely. I think very quickly that there were two. There was one, basically a group that was formed in the community for the care of people with diabetes to help individuals in underserved communities not only manage their diabetes better, but then develop community workers who can work individually with individuals to help get them access to services, be able to manage their diabetes. This was started as a grant, essentially, in order to get that done, but the grant money stopped. But the community members picked it up, and they continued with having that sort of that social network, which they can help themselves out, getting money where they can with donations, but continuing that forward. And I wish Dr. Charrington, who's the PI of our center, was here because that's been one of her major victories. The other one is breast cancer, a similar sort of situation in which women from underserved communities were given an opportunity for navigation in terms of the system and being able to access care. But when the grant funding ran out, those individuals saw so much value in that they continued that program moving forward. So I'd be happy to get you in contact with Dr. Monica Baskin, who runs, who did the breast cancer part, and Dr. Charrington, who's going to give you their ideas because you know, they are really the ones in our area that have been the best examples of that.
Well, thank you, Dr. Gutierrez, for this outstanding presentation again. And we also want to thank the audience for their participation. And on behalf of the Investigator Development Unit, we thank you all. Have a wonderful day.
Thank you so much. That was terrific.
Bye-bye.